Should I start,
So,
Sandeep?
so should I? So I will start from first. Good evening, everyone. I am Dr. Jairam Navde. I am working as a consultant in critical care medicine at Raheja Hospital, Mumbai, and chairperson of ISPEN Mumbai branch. I welcome you all to today's sixth webinar of ISPEN Mumbai branch on a very important topic, glutamine in clinical nutrition. Thank you, Dr. Sanjit sir and ISPEN for allowing ISPEN Mumbai branch to conduct this webinar. I am inviting Dr. Sushma from the ISPEN Pune branch. She is the organizing secretary of the ISPEN National Conference. She will tell us about the upcoming ISPEN Pune National Conference. Over to you, Dr. Sushma, madam.
Thank you. Thank you, Jairam. And thank you, Sanjeev. Good evening, everybody. I am from ICCM Pune branch. I am now acting as a secretary for ISPEN 2024 Pune 19th annual conference of Indian Society for Parental and Enteral Nutrition, which is to be held on 30th November and 1st December. So we'll be carrying out workshops on 30th, which will be an half day, and after that in the evening will the ball of conference will start with the scientific program in the evening starting at 4 p.m. This entire scientific program will be well organized and will be having panel discussions plus related to sports medicine also, or sports nutrition also will be covered. And we are this time starting our first initiative, that is a ISPN oration. We are in just going through all over India who has done a good work on nutrition will be invited for the oration. And the venue is also been decided. It is at the Novotel Pune Nagar Road. And the advantage of this venue is there is a direct to and fro metro convenience, or for the communication it will be easier for everybody, right from station or Shivaji Nagar to directly. It is the last stop in front of Novotel Nagar Road, Pune. So the highlights which I said was of the workshop and the scientific program. Here we are also planning this time to, we had just had a meeting 1 week back, and we have planned a workshop for the nutrition in nursing, or for the nurses, what they have to be aware of. That we are planning for that, and we have included all of the dietitian from Pune, and we have formed a scientific committee and a different workshop committee also. Soon, within 2 weeks or so, we'll flag out the entire scientific program, and we invite you personally. I also invite everybody for this 90th annual conference, which is to be held in Pune. And this is what it is, jointly organized by ISPEN Pune branch and ISCCM Pune branch. So as I said, 30th is Saturday, and Sunday will be the 1st December, which will be a whole day program, right from morning to 5 o'clock. We'll be having the extended programs. Then this is the venue, Hotel Novotel Hotel Nagar Road, Pune. And this is the table arrangements. Upstairs, we have booked two. That is the first floor. We have an entire for the scientific program or for the conference. And upstairs, we have boardroom. And these are the boardrooms where we can break up for the boot camp. And one of the room also can be used, or maybe Ruby Hall will be conducting the workshop for the nurses. So this is the thought process we have had, and we welcome you all for the conference. At a big number, we all expect you all here in Pune, and we are all beginning our preparations to give a good scientific program to you all. Thank you. Thank you.
Thank you, Sushma, madam, for giving us time on a very short notice. Kindly attend this very important and informative webinar till the end so that we can have a fruitful discussion. And if you have any queries, kindly ask in the chat box. Today's session is moderated by Dr. Sanjit Shashidharan. He is the Director of Critical Care at SL Raheja Hospital. He is also President of ISPEN. He is a very dynamic and enthusiastic person. Over to you, Dr. Sanjit sir.
Um, yeah, thank you, Dr. Jairam, and thank you, Dr. Sushma. I am definitely geared up to actually attend the national conference in Pune, and knowing Pune's exuberance in scientific activities, I know that is one conference that we will like to watch out for. A conference that is going to actually open up domains with respect to nutrition, not only in the critical care domain, but also in various other parts, including sports medicine, nursing, nutrition, and things. As the president of the Indian Society of Parental Nutrition, I welcome one and all for that particular conference, and I don't want to miss that. And none of you will also want to miss that one. Meanwhile, Sushma, if you could just share Dr. Gunadhar's, unshare your screen so that Dr. Gunadhar could share his
Yes,
screen.
I stopped
Yeah.
sharing.
So Dr. Gunadhar is a friend, a close friend of mine, and he's the head of the department at the Apollo Hospital, Navi Mumbai. He has got many credits to its name, which includes a large amount of data on science. At the same time, he has been running one of the most busiest hospitals in the city of Mumbai, in Navi Mumbai actually, and we all look upon him as one of our friends who does a lot of ethical work when it comes to critical care. However, what he's going to take today is something extremely controversial. I think there is nothing more controversial in the field of nutrition than the use of glutamine. In critical care, it is controversial. In medicine, it is controversial. In cancer, it is controversial. It is one of the most controversial units, biosynthetic product that has been the bone of many contentions, and I think we like to look at the diverse usage of glutamine, which has been there, and we look at the evidence about this. Now, what I must tell you is more than half a century ago, Harry Eagle noticed that the supplementation of glutamine at millimolar levels in tissue culturing medium could robustly enhance cell growth and proliferation. That is the primary reason as to why glutamine is supposed to be so good. I mean, it is responsible for cell growth and proliferation, and this means all cells. And let's go to Dr. Gunadhar without wasting much time and ask and learn from him. I'm going to learn a lot during this webinar. Over to you, Gunadhar, about glutamine. Let's hear from you.
Yeah, thank you.
A small housekeeping announcement, sorry, Dr. Gunadhar, is if anybody wants to have any queries, please post it in the chat box immediately, and we will address the questions by the end of the entire session. Thank you, Dr. Jairam.
So thank you, Dr. Sanjit. Always remain dynamic. I think from my training days and when he is my senior, and from that time, I think this topic actually, it's not today's discussion. From 2010, 2012, 2014, 2018, every time Dr. Sanjit has involved us, and particularly, I think I am one of the person who is most debated, giving the most discussion on this topic in my Sion Hospital days, and then followed by the Nanavati days, and then coming to the Apollo days. And Dr. Sanjit is very famous for that because he always keeps intensivist on the toes, because you know that he always selects the topic which is actually having no clear-cut answer. So with this background, so let's just wrap up the certain things. I can see it is just a discussion. So whether this glutamine is rightly told by Dr. Sanjit is a friend or a foe. So basically that we need to decide. So as a dietitian or clinical dietitian and nutritionist and the intensivist, the whole community needs to come to a common point whether this patient needs a supplement of glutamine or not. So there are a lot of literature, as Dr. Sanjit just now told. So starting from the older days to lot of the search when I made in the database, particularly the PubMed, the ISPEN, the ESPN, the NEGM, the Science Direct, and particularly I also went through a few of the thesis topic, very interesting thesis topic in some of the which I found on the net actually. So particularly in the European countries where the students have worked a lot on this, the glutamine kinetics particularly, it is very important to understand that thing particularly, which I didn't find particularly in the Google or up to date. So the mystery remains continuous, but let's see whether we can able to solve certain mysteries behind it. So why this mystery is there actually. So we all know that, and these are the proven fact actually. So whether it is a high glutamine level or low plasma glutamine level, so the mortality in the ICU is very, very high. So this is one of the substance where, like, if the patient having a very high glutamine level, so it directly contribute to the mortality, which is a very interesting and I think one of the very take-home message. So that is the reason, because whenever it comes to the mortality, particularly the as a intensive care specialist, we are very much concerned. Anything which like either decreases mortality or increases mortality, actually that should be always taken as a one of the, you can say, the line in our dictionary actually. Okay, so this is one of the thing, and less is more or more is less. Actually, don't know what is that actually. Whether you have to give the less glutamine supplement, no glutamine supplement, more glutamine supplement, and how does it like you have to give actually. That is also still very much debatable. Whether you have to give IV, oral, and heterogeneity is the rule. So most of the times you find that it is rather an exception in such a molecule. Like if you consider the patient population which varies starting from a body build to athlete to a patient who is admitted in the intensive care unit, like a patient who is very sick and patient who is suffering from cancer, a patient who is taking chemotherapy, or a patient who is taking a lot of this GI problems. So population, whether it is a female, male, or whether the disease condition, as I already spoken, like renal failure, liver failure, and severity, starting from mild, moderate, severe, what grade of the severity the patient is having. So this is a always a matter of discussion. The pharmacokinetics, of course, is a very robust, and I can say the glutamine is such a molecule. Actually, it is very important to understand the pharmacokinetics and pharmacodynamics, how the glutamine, what the glutamine does to the body, and what actually the body does to the glutamine supplement. Something called as chameleon molecule, I can say, because see, in health the behavior is different, in the disease the behavior is totally different, and in sometimes in a patient who is immediate post-op and immediate undergone any surgery, a athlete who is like doing a gym, is a totally the behavior of the glutamine levels in the body is different. That is why it is called the chameleon molecule. Okay. And something interesting facts, this is very important because it is one of the very common, most abundant free amino acids in the human body with the molecular weight. And sometimes you can see that 20% of the free amino acids pools in the plasma is contributed to glutamine, such a on the higher level. Production kinetics is self-regulated. Very interesting to note that if the glutamine level goes high, it has a mechanics to down-regulate itself, its production. If the level goes down, it has a mechanism to upgrade its production. So that is the very important fact about the glutamine level, because most of the enzymes involved in the glutamine synthesis and the glutamine degradation, they are either allosterically modified or they can be covalently modified. So that is the beauty of this molecule, that the body has an innate mechanism which it can regulate its own production. The glutamine supplements, if you give through the IV route, oral route, the kinetics always happen in a very robust manner. So most of the IV glutamine that actually goes to the body, it basically mostly goes to the systemic circulation. The oral glutamine supplement, most of them are being utilized by the gut actually, 40 to 50%, and then it goes to the systemic circulation. So this is the cycle that runs throughout your body, day, night, everywhere, in the critical illness, in the health, in your intensive care unit, whether the patient is having any kind of medical issues, cancer, oncology. So this is what basically the glutamine is a simple molecule, but when it is being taken inside the body, you can see the glutamine being converted to glutamate. So there are two names which is very important in this context. One is glutamate, second is oxoglutarate. And there are two enzymes which is very important. So one is called the glutaminase and second is called your glutamine synthetase. So glutamine synthetase is an enzyme which convert glutamate to glutamine. And glutaminase is an enzyme which breaks down the glutamine to glutamate. So this is such a dynamic process. So because the glutamate is glutamate which is remain inside the cell, it is highly unstable. That is the reason whenever there is a free glutamate available inside the cell, it immediately give rise to a lot of byproducts. So the byproducts can be in the form of GABA, which is very helpful in neurosignaling. It can convert into glutathione, which is an antioxidant. It can be converted into glucose via gluconeogenesis pathway, and it contributes to the production of the glucose in case of severe critical illness. It can convert it into something called as ornithine, arginine, and urea, and that also sometimes it can be converted into ornithine via arginine, and the arginine, as you know, via the nitric oxide pathway, it causes nitric oxide synthesis, and that nitric oxide is one of the molecules which is involved in induction of apoptosis, destruction of the microbes and cell signaling. So this is basically helpful in stimulating your leukocytes. Okay. So, and the glutamine, as you know, the glutamine, if there is more or excess of glutamine in the body, it can be converted into nucleic acids, nucleotides, the protein synthesis, and that also sometimes leads to RNA and DNA synthesis, and that leads to cellular proliferation. That is, whenever there is a new budding cells, or whenever there is a the cell which is growing, they require always glutamine for their growth, for their maturation, for their support, and of course that also for their division. That is the old is fact actually. Glutamate also can be given rise to urea synthesis pathway, and sometimes, because so whenever the body urea levels are very high, the urea binds with the glutamate, the ammonia binds with the glutamate, and this can convert to glutamine. That is the reason glutamine is one of the important amino acid which helps in the detoxification of the ammonia in the body, and that is the reason why in the most of the times in the liver failure, the patients of liver failure suffers from hepatic encephalopathy, that I am going to show. So this is a simple cycle: two byproducts, glutamine to glutamate, and glutamine is stable inside the cell. Glutamate doesn't remain stable. That is the reason glutamate converted into a lot of things. The glutamine inside the cell, when the amount is excess, that leads to osmotic absorption of the water, and thus there is a cellular swelling. That is the reason whenever there is excessive glutamine, that leads to also cell death, because it causes cellular swelling. Whenever the glutamine level decreases, that leads to cellular dehydration. And glutamine is such a molecule that freely transported across the cells. So this is the only, because glutamate cannot cross the barrier so easily, but glutamine can. So that is the reason the glutamine, always the glutamate get converted into glutamine for the intertransport of the cells. So this slide actually tells us that how the glutamine level is being regulated in the health, and second is glutamine level is being regulated in the critical care illness. So let's come to the health first. So these are the different compartmental models. So before knowing glutamine, we should know what are the different compartmental models inside our body. So basically, these are the different compartments. The compartments start from brain, comes to the lungs, to the intestine, the gut, the liver, the immune system, the skeletal muscles, the fatty cells or adipocytes, and the kidney. So whenever the person doesn't have any disease, so particularly this is the glutamine pathway, and the glutamine level in the blood is regulated in this manner. So basically here, what happens, you just look at these white arrows and the green arrows or blue arrows. So the blue arrows means the glutamine which is synthesized in different organs, it comes to the blood in the healthy condition. So primarily in the healthy condition, the most important source of glutamine in the blood is the skeletal muscle. Second is the liver, and third to some extent is the lung. So because these three organs, basically they are enriched with this enzyme glutamine synthetase, and in health they basically means from the protein or amino acids, and from the protein breakdown they take glutamate and they convert into glutamine, and they release the glutamine into the systemic circulation. Whereas in the intestine and in the immune system, the cells of the immune system, the cells of the kidney, they always depend on the blood for the glutamine requirement. So whenever there is a glutamine level which is exceeded in the blood, they automatically being utilized by the kidney, the gut, the intestine, and sometimes by the brain also. And most importantly, the immune cells, particularly the neutrophils and the lymphocyte, particularly they utilize this glutamine from the blood actually. So this is the tuning between the demand and the supply, and basically the production versus the consumption. This is how the cycle takes place in the health. But what happens in the critical illness? You just compare the same figure, that whenever the person suffers from a critical illness, which ranges from mild, moderate to severe, you can see the cycle is just reversed. So instead of liver, which is a good producer of the glutamine in the health, now you see the liver is now started consuming the glutamine actually. So that is why the requirement of glutamine tremendously increases 5 to 10 times in a critical illness. That is why the biological possibility is that whether glutamine supplement can help to increase, mitigate this requirement of the glutamine, and help to prevent the stress response of the critical care illness. So basically the liver, the immune system, you can see the immune system, which normally requires say suppose X time the glutamine or the glutamine amount in the blood, now becomes the requirement of the immune system become 3x time, 4x time, or 5x time. This is how the pathophysiology happens in the critical illness. Similarly, you can see the kidneys and the requirement to the brain that remain unchanged. but actually the gut here, actually this suffers also. And there is a, you can see the in the critical illness, there is a slight decrease in the glutamine requirement of the gut. And that because of a lot of things actually. Okay, that we'll discuss actually. Okay, so this is how the glutamine cycle and the compartmental models in health and the critical illness, it happens inside the body. So this is what about the nutshell. So it is ultimately depends on the glutamine pool. So in the critical illness, we know that the glutamine pool got depleted, and the glutamine pools supply different, or it can create the different chemical mediator which are helpful for the body. So particularly the glutathione, which helps in fight the oxidative stress. And whenever the glutamine pool decreases, the glutathione level decreases, the antioxidative capacity goes down. That also leads to increased mortality. Whenever the glutamine pool decreases, there is a decrease in the cellular defense mechanism that leads to increased mortality. Whenever the glutamine level decreases, there is an inadequate supply of the fuel for the enterocyte, and that leads to decreased intestinal barrier, and something called as that the mortality also increased. The proliferation and function of the immune cells also hampers, that leads to decreased immune competence, leads to decreased cellular energy supply, and ultimately that leads to cell death. And of course, the all this leads to severe breakdown of the muscle mass, and the patient suffer from the something called as a catabolic phase. So hypoglutamia and hyperglutaminemia. So which is like most of the times it is very prevalent. Actually, it is more prevalent than we think actually. So in health also sometimes we don't find adequate glutamine level in our body, like in a physiological state when somebody exercise. So basically in those states also there is a rapid degradation of the glutamine from the muscles and the muscle breakdown. That is the reason. So a lot of there are a lot of like off-level use of the glutamine, which is mostly being done by the athletes, and to make this muscle tissue more and more you can say the strong to fight with the exercise stress and all. So let's see what are the different conditions where you see the low glutamine level in the blood actually. So okay, so these are the different studies and the different literature which suggests that polytrauma is a condition where the glutamine level in the blood rapidly goes down. So this is because of the multiple factors. So this is because of the rapid utilization by the cells, because of the stress response, because of the inflammation, because of the severe, you can say the muscle breakdown, and because of the, you can say the reversal of the glutamine flow towards the liver, and because in case of severe surge response. Major burns, particularly if the burn area is more than 15% to 20%, this produces a severe catecholamine surge and release of the stress hormones, and that also leads to severe inflammatory response syndrome, and ultimately the glutamine cycle reverses. So this is a proven fact. The major burns patients, they are deficient in glutamine. Acute phase of any critical illness, where immediately you know that in the critical illness there are three phases which predominate. One is the acute phase, one is the chronic phase, and one is the intermediate phase. In the acute phase we get a lot of inflammatory mediators, and those are responsible for tissue damage, those are responsible for the stress response, and this is where the lot of glutamine being consumed by the all the immune system cells, the intestine, the liver, and that leads to fall of the glutamine level in the body. Inflammation and active infection. So that is the reason glutamine supplement sometimes helps to alleviate the inflammation, and it helps to also prevent, or sometimes it can heal the infection in a much better way. So this is how the mechanism inside the gut operates. Basically, intestinal mucosa is one of the cell which suffer earliest, because the turnover is rapid and the demand of the glutamine in those cells are quite high. So any condition where there is a sudden decrease or sudden fall in the glutamine levels, particularly the intestinal mucosa, they suffers, and that leads to disintegration of the intestinal mucosal activity, and ultimately that leads to inflammation, and that leads to gut translocation of the bacteria. And we know that most of the times in the critical care illness, the gut translocation by the bacteria is one of the commonest hypothesis which is postulated, where the sepsis spreads rapidly. That is the reason. So early feeding always helps, like the whatever the ISPN and ISPEN guidelines says actually. So you can say the glutamine, which is responsible for generating the heat sub proteins, which is responsible for generating all these anti-inflammatory mediators, the growth factors, all these things, they suffers particularly in the intestinal mucosa. That is the reason there is a rapid shedding of the intestinal tissues, and there is also alteration of the intestinal flora actually. That also leads to gut dysbiosis, and this is now a recent concept which is coming more and more in a way, that the gut dysbiosis is very common in some of the critical care illness, and we have to prevent it actually. So glutamine concentration in cancers, you can find that, see, this is a lot of the trials have also shown that the cancer cells, they consume the glutamine more compared to the normal cells. And also there is a severe glutamine deficiency, which varies from regional area to the peripheral area to the central area of the cells. So you know that, so basically in the normal tissues and the tumor tissues, so in the your regional glutamine deficiency is more prominent in a tumor tissue compared to the normal tissue. Okay. Similarly, the regional glutamine deficiency is more prominent in the core tissue rather than the peripheral tissue. And that is the reason. So whenever these patients, they get glutamine actually for the normal nutrition of the cells, the cancer cells. So this is now ongoing research where there are a lot of papers are coming up with to supply the glutamine supplements, in particularly in patients of oncology patients, also when they are undergoing chemotherapy and radiotherapy, to prevent the radiation injury to the tissues and to prevent the mucositis involved with the radiation and the chemotherapy drug. The systemic glutamine deficiency also shows the same trend, and this is what the imbalance happens whenever the patient suffer from a cancer and major cancer, and that leads to increased consumption by the cancer tissues. Now, very high glutamine level. So this is also a very important thing, because most of the time the patients in ICU, he is having a multi-organ failure with a liver failure, with a kidney failure. And this has been found that particularly patients with acute fulminant liver failure, the glutamine levels goes very high. And that sometimes can be a marker of the severity of the liver injury. And that also prognostication of one of the prognostication factor for the mortality in such patient actually. Rapid cell lysis. When there is a rapid cell lysis, particularly in a patient with tumor lysis syndrome, or particularly in a patient where the cells are rapidly lysed, the glutamine inside the cell are being released to the systemic circulation, and they are contributing to the very high glutamine level in your something called as the tissue actually. Acute kidney injury. So whenever the person suffer from the acute kidney injury, the glutamine levels that accumulate in the body, because the kidney is one of the organs which consume glutamine actually. And why the kidney consume glutamine? Because it is one of the detoxification process. So to prevent acidosis and to convert bicarbonic acid to the bicarbonate ion, your glutamine is required. So whenever the body has severe acidosis, the bicarbonate ion or the carbonic acids, basically it requires glutamine. The ammonia which is released from the glutamine, it can convert into the bicarbonate acid, can be converted to bicarbonate, and that leads to prevention of the metabolic acidosis. Many of the metabolic disorders, particularly the insulin resistance, and particularly in patients with obesity, and particularly in the patients with particularly metabolic syndrome. So like your maple syrup urine disease, where there is a lot of inherent disorders of other amino acid metabolism. Similarly, the glutamine metabolism also suffers. So particularly in these patients, you find a very high glutamine level, and that sometimes is a very, very dangerous. So this is basically the physiological phenomena or fact behind the glutamine role inside the body. But of course, we know that nowadays, so the debate still continues whether it is a savior or whether the high glutamine level can be sometimes it is a sometimes called a killer. So that also needs to be discussed actually. So what we as a medical person are involved in the RCTs, evidence-based medicine, and sometimes the studies. So we are in era of 2024 actually, where we cannot just do the practice like this. So evidence-based medicine is the best practice. So let's see. So what are the evidence actually being there actually for the glutamine and oxidative stress in the critically ill patients? So in a critically ill patients, the oxidative stress contribute to tissue injury and influences the clinical outcome. This is a proven fact. And we know that this oxidative stress is being mitigated by the glutathione, and glutathione is a byproduct of the glutamine. So that is the reason there are a lot of randomized control trials, a lot of RCTs, and a lot of other studies. There are small center studies, there are medium center or there are middle-sized studies which says that early enteral nutrition with high doses of glutamine, particularly 50 to 60 grams, and antioxidants improves the sequential organ failure assessment score. So here they have not commented on the mortality, but they have commented on the sequential or the SOFA score, and SOFA score is one of the important predictor of mortality and morbidity in ICU patients. So the initial SOFA score at the time of admission and follow-up, if the SOFA score goes up in an ICU patient, that actually contribute to the mortality. So indirectly this is a contributor to the mortality. So that is why high glutamine supplementation in such patients sometimes improves the SOFA scoring system in 24 hours, 48 hours, and 72 hours. So the other thing is that glutamine is a very good role in cellular protection. And as you all have discussed, like the hits of proteins. So HSP proteins, like this is one of the proteins which is involved in protection of the cells. How it helps in protection of the cells? It basically prevent the apoptosis and cell damage. And so this is one of the common target going ahead further for the treatment in human sepsis. I think a lot of literatures and a lot of studies are being undergoing to study the role of hits of protein. We know that sepsis is a same like glutamine is a heterogenic disease, and basically we have to need a lot of studies in this respect. A lot of newer upcoming areas still being explored. So particularly in a surgical intensive care patients, so this has been found that in many of the studies that if it is enriched with glutamine, that sometimes improve the survival, or sometimes decreases the hospital length of stay, decreases the ventilator days, and it improves the patient's outcome to come out from the ventilator easily. So it has been also fact that the glutamine enriched with nutrition. So they have not only studied with glutamine, but glutamine enriched with other nutrition probably increases the hits of protein level after 7 days, and that finding that correlate with the decrease in the ICU length of stay. So there the main primary outcome is the ICU length of stay, not the mortality. Okay. So this is also another well-known fact, like the gut barrier dysfunction, as we have just discussed, how the gut mucosa suffers in sepsis and inflammation, and how the gut is being prevented by a glutamine supplement. So intestinal integrity is secured intact, and you know that for the your maintenance of the cellular lining of the intestine and maintenance of the tight junction, glutamine is a very important element, and which actually help in the cell growth and help in maintaining the cell lining and the cell barrier. That is the reason whenever the person is having a leaky gut syndrome, particularly in cases of leaky gut syndrome, particularly in a sepsis or SARS, acute pancreatitis, particularly in a case of your multi-organ failure, this leaky gut is a very, very dangerous thing. And basically this leaky gut syndrome is prevented by supplementing with glutamine. And this is a finding that whenever this kind of things happens, this also jeopardize the glutamine depletion. So that is also the reason. So you have to supplement this patient with the glutamine enriched nutrition actually. The gut barrier dysfunction is, I already told you, it promotes the bacterial and endotoxin translocation. And of course, the nitric oxide synthetase. So this enzyme, which is basically involved in maintenance of the tight junction, and this enzyme actually comes from the glutamine actually. I have shown you the pathway. So basically, to maintenance of this enzyme depends on the supplement of the glutamine. That is the reason whenever you supplement glutamine, there is a attenuation of the cytokine release, there is an increase in the hits of protein expression, and the reduced gut mucosal apoptosis. These are the few studies, the randomized trials, a well-known fact, lot of guidelines, whether you say ISPEN, ISPEN, or sometimes Canadian nutritional guidelines, the Indian guidelines also, the burn patient particularly. Glutamine is a very good, you can say, the anti-inflammatory agents, particularly it is a very good nutrition to support this burn patient. And particularly it will also help to alleviate the inflammation and the catabolism associated with severe burns actually. So this also improved to heal or promote the wound to heal the wound better way, and also it promote this decreases the hospital stay in a burn patient because of lot of reasons. So one is anti-inflammatory property, second is improved gut integrity, third is enhance the immune function, fourth is modulation of the inflammatory response, and of course all of this leads to reduction in the gram-negative bacteremia in the burn injury patient. That is the reason there are evidence which is there actually, in particularly in a patient of polytrauma and particularly in a patient of burns. No doubt about the things that this patient, they require a glutamine supplement whenever this patient come to the ICU. Sepsis, I'm not going to go into the detail because sepsis is a still controversial topic. There are studies which shows that the sepsis patient, if the glutamine levels are low, they should be supplemented. But a lot of times when the patient in sepsis has a multi-organ failure, has a liver failure, kidney failure, the glutamine level indirectly increases in the sepsis patient, and that also indirectly contributed to the mortality. Okay, so that is the reason this is a very, very controversial topic. But of course, if the glutamine levels are low, I definitely find many of the literature which suggests that this should be supplemented with enteral glutamine, particularly to maintain the level. Insulin sensitivity. We know that the insulin resistance happens when there is a glutamine deficiency in the body, because the pathway which I have shown you, particularly the glutamate, which is very helpful to promote the insulin sensitivity in the critically ill patient. That is the reason whenever the glutamine levels drop down, that leads to insulin resistance, and patient can develop all the complications because of the insulin resistance, particularly diabetes mellitus, uncontrolled diabetes mellitus, the deranged blood sugar. And it has been a well-known fact that if the blood sugar level fluctuate, particularly in the critically ill patient, that is more detrimental rather than a single value of fluctuation in the blood sugar or absolute value of the blood sugar. That is the reason your glutamine level is the critical care illness progresses, there is a lot of fluctuation in the glutamine level, and that also indirectly leads to fluctuation in the level of the blood sugar, and that leads to indirectly contributed to the increased length of the stay, increased hospital stay, and increase your ventilator days in particularly the critical care patients. Though this is not deal with the critical care patient, but sometimes the literature says that the glutamine helps in your prompt healing of the diabetic foot infection actually, because this is also the studies has been shows that the glutamine aids in the collagen synthesis and the tissue repair. That is why it helps in the healing process. So that is why the patients who are deficient in glutamine, potentially leading they should be supplemented. That leads to less pain and the faster recovery of the diabetic one. Anti-inflammatory function, no need to discuss again, because of all these inflammatory markers, it has been found that they drastically reduced with a appropriate glutamine supplementation. Particularly the immune modulation happens. So this is called one of the immunomodulators. So what is an immunomodulator? So when we give something which actually modulates the immune system, and the supplement is given the amount which is required more than the normal amount, that is called the immunomodulator or immunonutrition actually. So not only glutamine, so there are a lot of immunonutrition like selenium, like glutamine, like your omega-3 fatty acids, which is being studied extensively in last decade actually. So this is glutamine is one of the component, and it has been found that it helps to it helps particularly the monocytes and the lymphocyte to it's basically to help them to combat with your antigens in a better way, because for the better antigen presentation to the helper T cells, CD4 cells, the glutamine is required. Okay, and also in the trauma patient also. So basically this also helps to combat the inflammation, severe inflammation in a polytrauma patient. So that is the reason. So it has been found that the surgery, trauma, and the inflammation, there is a reduction in the HLA-DR expression in the monocytes, and supplementation of the glutamine helps to restore this HLA-DR expression, and that leads to preservation of the monocyte function. Cancer treatment, I just also discussed regarding how the glutamine supplement helps to help the tissue to like the cancer tissues to actually the fight with the normal tissue to fight with the infection when there is a tumor actually. So basically it has been found that the supplement diminishes the tumor growth by restoring the function of the natural killer cells, improve the protein metabolism, it protects against oxidative damage, and also there are a lot of other mechanisms actually. But again, there are few newer trials or studies which have been coming up now that sometimes the cancer cells they survive on glutamine. So whether to give a glutamine supplement in such oncology patient is should be recommended or not, that is still debatable. But side effect of the cancers, particularly the chemotherapy, radiotherapy induced side effect, particularly the mucositis, that is definitely helpful with the that it definitely heals better in a glutamine supplement. Okay, so this is what the overall the data of the oncology patients. So this is what basically, this is I think one of the area where the largest research has happened, particularly in the skin and the oncology patients. So oral glutamine particularly was shown to be very, very effective in treatment of your tumor related mucositis, the oncology related mucositis, and the review also suggests that these dose should be vary from 30 gram per day, particularly in a 3 divided doses. So favorable efficacy and low toxicity of oral glutamine is observed in clinical trials, and that also provides a strong rationale for large randomized placebo-controlled studies to further evaluate its efficacy in preventing mucositis. So we still require very large studies to come into this. So this is all about the small studies, randomized small studies or small center studies or few studies actually what I have shown you actually, though their impact factor is not that great, but actually the game changer or something the breakthrough happens when all these big trials have come in the glutamine, particularly the Scandinavian trial, the Redox trial, which is one of the landmark trial actually, the Signet study, the MetaPlus trial, and the something called the Instamin study actually. Okay, so this Redox trial actually was a very good, I think I can say one of the eye opener actually. So when this trial particularly like it is one of the trial which is taken into account a larger number of patients in the range of almost I think 600 to 700 or more than that, and they have taken into account all the mechanical ventilated patients with more than 2 organ failure, and they have considered the very high dose of parenteral plus enteral glutamine supplement, and they have provided this supplement throughout the ICU stay, and particularly median time of 8 days. And the outcome is that most of the times they have found that it actually increased the mortality. So why I'm focusing on this REDUX trial, because basically if you see the patient population, they are very, very heterogeneous. So you see the patient on mechanical ventilation, more than 2 organ failure, and within 24-hour admissions where the patient is actually sick, where the dynamic process has changing continuously, the physiological parameters are changing continuously, and of course they have used a very high dose of glutamine in such patient. Not only glutamine, actually they have 4 arms where they have given the immunosupplement. So whether it is only the glutamine or it is the other immunosupplement like the free fatty acids, the omega-3 fatty acids, or the selenium, or the vitamin C, the vitamin E, that has contributed to the mortality, actually we don't know actually. But this is one of the largest trial, actually I can say, which actually has a point of debate in 2012 actually. Okay, and after that, so a lot of trials, the Signet trials, the Meta Plus trials, the Intermin trials have came. Though the Signet trials, the numbers are still less, the Meta Plus still less, and the Instamin trial only have taken into 50 to 100 patients, I think 50 to 60 patients. And we can see that, so most of these trials, they have taken the enteral glutamine supplement, and that is not on the very high dose. So particularly the standard dose, and they have supplemented for 10 to 12 days, and they have found out that sometimes there is no mortality your problems, but there is not much benefit actually with this kind of study actually. So there is like you can say there is not much benefit also, there is not much harm also actually. So these are mostly, sometimes you can say, the neutral study actually. So, but the Scandinavian glutamine trial, definitely the parenteral glutamine, which is being used. So throughout the ICU stay with median of 9 days. And basically here the patient population, they have stabilized the patient within 72 hours of admission, and the patient are receiving more than 80% of the full nutrition. And here also there is no tendency towards mortality, but there is no outcome benefit actually. So this is all these trials have failed to show a major mortality benefit in the clinical practice. But definitely, if you see the length of stay, the hospital length of stay, the days on mechanical ventilator, the discharge from the ICU is definitely shortened. And that is why the focus, or the world is thinking whether the glutamine supplement should be ideally adopted as a routine clinical practice in most of the ICU patients. And this study, the Meta-Gluta-ZS study, actually, it is particularly the oral and enteral glutamine supplement in patients following major cardiac surgery. And this is through with type 2 diabetes mellitus. This is a very good study, though the number size is very small, but I can say that it is a randomized control trial, and patients are randomized, randomly divided into 2 groups. One is a glutamine supplement group, and which is being administered oral and enteral glutamine. And second is the experimental group, and they have been given glutamine supplement for 3 days post-surgery, immediately after the feeding has started. So here they have assessment being done with TLC, the lymphocyte count, the platelet count, the total proteins, the serum albumin level, the infection rate, the length of the stay, the hospital stay, and the mortality. And so what is the observation actually? Okay, so this is the observation, is that the result is that the study has provided evidence that the supplementation of oral and enteral glutamine in post-operative patients in elective cardiac surgery decreases the incidence of post-surgical infection. It shortens the ICU stay, it shortens the hospital stay, and it overall reduces the overall hospital cost. So this is a very important point, because it overall reduces the hospital cost actually. So that is the reason. So if you find that the patient is undergoing a major surgical procedure, cardiac surgical, we consider the cardiac surgical procedure to one of the major surgical procedures. So in this group of patients, sometimes, or I can say, we can think of replacing the glutamine if the initial glutamine levels are very low, if the patient is having inadequate nutrition, or we can build up his nutrition also, and then think of supplementing the glutamine level after the patient has undergone a surgery actually. And here we can also see that in the post-operative group, where the patient has received the glutamine supplement, the most of the times we see that their infection markers, they are being almost in the normal range compared to the experimental group. Sometimes they may throw a surge response or surge response actually. Okay, so that is why this is where considering the role of glutamine as an antioxidant, we can definitely think that this is in a surgical patients, this definitely helps actually. And after that, comes the guidelines. So what are the different guidelines? So ESPN guidelines, ISPEN guidelines, and other organizational guidelines. So the ESPN guidelines, so I can say this guidelines is more cautious in recommending glutamine as a nutritional supplement. They have given 20 key recommendations based on the ISPEN guidelines regarding the glutamine supplementation in the ICU and the critical care patients. So what we can think of that, so they have divided the patient group. So first thing is that whether we should supplement in a routine medical patients, in a critical care patients, patient with organ failure, or patient with post-surgical patients, or patient with burn and trauma. So these are the 5 categories of patients, and they have recommended that before supplementing glutamine, you have to individualize assess the patient actually. Not every patient is same. So that is the reason comes what is called as the individualized approach, the precise approach, and the something called as the individualized approach. So this is the reason where you have to assess the individual patient's clinical condition, nutritional status, overall treatment plan, and then plan for the glutamine supplementation actually. The timing of the supplementation, so initial glutamine supplementation should be early in the first earlier period, and ideally within the first 24 to 48 hours to support the immune function and the intestinal integrity. The dose is 0.2 to 0.3 gram per kg body weight per day, depending on the patient's need and tolerance. This is not very high. Okay, and this is not very low also. So more than 0.5, 0.6 gram per kg is considered to be a high dose of enteral glutamine. The route of administration, always all the guidelines, they support the enteral administration compared to the parenteral administration. We know that the L-glutamine is easily absorbed through the intestinal mucosa. Glutamine in the standard parenteral preparation is not stable. That is the reason they are mostly available in the form of dipeptide. So what they have suggested is prefer the enteral administration whenever possible. Okay. Patient selection, duration of supplementation, safety monitoring, renal functions, hepatic function monitoring, and combination with other nutrient. These are the different recommendations from their side. They have also recommended that consider combining glutamine with other amino acids and antioxidant to enhance its beneficial effects on the immune system and the gut barrier function. And the contraindication is that is a routine contraindication. Any patient with hemodynamic instability or uncontrolled shock, particularly the glutamine level, it goes very high because of the multi-organ failure. So those cases, they have not recommended the glutamine. And sepsis and infection, as I have already pointed out, that this subgroup remain the controversial, and this risk should be balanced against the benefit actually, or the risk should be weighed against the benefit. That is the reason you have to be very, very judicious in administrating glutamine in sepsis and patient with severe infection. But of course, there is no doubt that they have strongly recommended burn and trauma, particularly burn surface area more than 20%, and polytrauma patients and surgical patients. Those category of patients, they definitely recommended the glutamine supplementation. Muscle wasting, and of course, so whenever you find that the patient is having a significant muscle wasting, to prevent the muscle wasting, and when the patient is undergoing a catabolic phase of the critical illness, you can supplement in the standard glutamine dose. Okay. Then also, like always reevaluate your patient whenever the patient is in the critical care. Always reevaluate and see the response of the glutamine supplementation, and adjust the dose or discontinue the use whenever the possible actually. Whatever, now come to ISPEN guidelines. So let's see how does the ISPEN guidelines actually tells us compared to the ISPEN guideline, which is more cautious. ISPEN guideline, I can say it is more conservative actually. So they have not strongly recommended, but same recommendation they have given for the patients with polytrauma and burn. They have suggested that these patients can get benefit from the glutamine supplementation, particularly the enteral glutamine supplementation, but also they have very, very conservative approach. They have also told that if your patient has a very not very, very unstable, or the patient is not very going through a critical phase, particularly in those cases, you have to absolutely see whether the patient is requiring a glutamine supplement or not, or whether he is going to benefit from the glutamine supplement or not. So this is what basically the ISPEN guideline regarding the doses of the orally administered glutamine. You can see the standard dose is 0.2 to 0.3 gram per kg per day for the first 5 days in case of enteral nutrition. If the patient is having a severe complicated wound, so in those cases, you can administer the glutamine for a longer period, almost for 10 to 15 days. And this is what the one of the strong recommendation from their side actually. And in patients with burn area more than 20% of the body surface area, you can also consider using additional enteral dose of glutamine, 0.3 to 0.5 gram per kg per day, and this should be administered for 10 to 15 days as soon as the enteral nutrition you start for that particular patient. So this is what the oral glutamine supplementation, particularly in a patient who is undergoing a radiation or chemotherapy, to prevent the radiation and chemotherapy induced mucositis. You can say the dose varies from 30 gram per day. Mostly the standard dose is 30 gram per day in a 3 divided doses in most of the trials and studies. And particularly the recommendation is that in case of oral mucositis or in case of severe diarrhea, you have to use it, or radiation induced any you can say the skin problem. Those are the standard preparation, which is actually helpful. And sometimes the duration can go up to 10 weeks actually, sometimes 3 weeks, sometimes 10 weeks, sometimes varies from depend on the how the patient showing the response. And sometimes the recommendation is, some of the studies they have found that you can start 1 month before starting the radiation until 1 month after completion of the radiation. So with all this like background, so whatever my take home message in this study, actually there is a lot of potential areas to be studied in a case of glutamine. So the areas which still need more and more rediscovered or more and more discovery, like what is like actual gut health and what are the status of the microbiome, we need to study in many of these studies actually. So particularly we need to have a lot of this your studies which should come up in a particular in a patient with leaky gut syndrome or inflammatory bowel disease. Particularly, we know that these are the two syndromes or diseases where the glutamine supplements help, particularly Crohn's disease and ulcerative colitis. We need to study a lot of roles of glutamine, particularly in immune system, whether it is a immune modulation or whether it is a inflammations. So in compared to the genetic, compared to the your genetic markers, and compared to the artificial intelligence based studies, and compared to the other data which is available in recent times actually. Oncology, we need to study about the tumor markers, the tumor growths, the tumor growth pattern, and the type of the tumor tissue which is being affected, or tumor tissue which is like grows more if glutamine supplements are being given. We need to study glutamine role, particularly in a lot of metabolic syndromes, whenever the patient is undergoing a lot of insulin resistance. Particularly, we have to need to monitor the C-peptide levels, obesity, particularly. This is one of the area which is still the studies are very, very few. Neurological dysfunction, particularly cognitive functions. We know that this amino acids helps to reduce the stress, anxiety, and also in a case of liver failure where the ammonia levels are very high, the ammonia that goes to the brain, it is easily diffuses through the brain, because in case of severe liver failure, because of the inflammation, there is a disruption of the blood brain barrier, and the ammonia which crosses the brain, actually inside the cells it converted into glutamine. So that is the reason. So whenever there is liver fails and the liver cannot produce urea in a normal pathway, it tries to decrease the ammonia level by producing more and more glutamine actually. So that is the reason sometimes this time the requirement of the glutamine from the external source to produce glutamate, because glutamate ultimately converted into glutamine inside the cell actually. So that is the reason. So we know that in a person with stress, that is why this amino acid is also called the calming amino acid actually. So lot of studies are now undergoing in the area of the Alzheimer's disease, so to see that how the effect of glutamine, particularly the memory and the dementia and other patients. Clinical nutrition. Now, ERAS protocol, they have included glutamine as a routine supplement, particularly for the surgical patients who are about to undergo surgery, okay, to enhance recovery after the surgical period actually. Sports nutrition. No doubt, this is a off-level indication. A lot of athletes they're taking for the endurance, for the muscle recovery, and of course, sickle cell disease, because of the antioxidant properties of sickle cell patients. So sometimes the glutamine supplement can prevent the sickling in such patients and prevent the sickle cell crisis. So whether this is actually helpful and this actually working, that also we need to see. So with this, so whether glutamine, it is an effective supplement or just a waste of money, it is us who can able to define, and whether there should not be any place that this molecule can go into the SOLAS in the near future, and more literature and more studies should be undertaken in this particular area to find the role of glutamine. And of course, I think Dr. Sanjit can highlight more than what I have discussed actually, whether we should use or not use and which subset of patient we should use. So let's discuss and let's finalize.
Yeah, so thank you, Dr. Gunadhar. As usual, an excellent lecture, and I'm very happy to have heard this here, and I'm certain all the attendees who have attended this, and also the panelists have learned quite a bit about glutamine from you. As I said, glutamine is a very, very versatile molecule, and it has been studied again and again all through, and it is something that has come in and gone out, come in and gone out. It is something that is very, very difficult to understand also. So just to answer this question, I'd want I'd like to ask Dr. Ravindra Reddy. Is Dr. Ravindra Reddy here? Sir, can you unshare your screen, Dr.
Yeah,
Gunadhar?
sure,
Huh?
sure, sure. Yeah,
Yeah.
sure.
Is Dr. Reddy here?
Yeah, I just joined.
Yes, sir. So we just wanted your opinion on say 5 cases where you would use glutamine for certain, and with reason, saying, okay, in this I will use, in this I may use, in this you must definitely use, and in this you must not definitely use. So maybe 4 cases where I would definitely use with some reasons because of that. And second is I would may use this. Third is I will surely use this, and fourth is maybe I will never use this. I will never recommend this this molecule. And you can take your pick whether it's IV or enteral in the particular condition that I'm asking. I hope the question is clear, sir.
Yeah, thanks, Sanjit. And before I start, my apologies for for joining you all so very late. We had some guests at home, and I wasn't too sure whether I will be able to join. But so here I am, and I feel bad that I missed most of Dr. Gunadhar's lecture. I was there probably for the last 2 slides or 3 slides, and that did give me an insight that perhaps he covered most of this. Now, Sanjit, your question of asking me what are the 5 cases in which I use, you are actually limiting the answer to only 5 cases. I actually use in 9 out of 10 patients I see glutamine. That is how versatile, that is how essential this particular molecule is. If one understands the physiological role of glutamine, one understands the production of glutamine. Incidentally, it occurs in the muscle, it's stored in the muscle. The production takes place in the lungs as well as to a certain extent also in the brain with the help of an enzyme called glutamine synthetase. So it's a very small molecule, so much that it percolates to almost all the tissues, and it has effects in most of the physiological aspects as well as in quite a few pathologies. Now, let me start by saying that where I wouldn't use. Now, for this, I need to fall back on redoxes, because even though redoxes is one of the most badly designed trials, this is from the horse's mouth, not from me. That is from Paul Wishmeyer when we were doing a tour together quite some time ago. I asked him, we all know what are the safe dose of glutamine and what made you all go to 60, 70 grams of using glutamine, both enteral as well as parenteral, and that too in patients whose Apache 2 is more than 12. In other words, very sick patients who had AKI, patients who had hepatic dysfunction. These are all the standard contraindications, and yet you have used it, and then you say that there is an increased incidence of mortality in these patients. Obviously, people will die when you use them. So in other words, where I wouldn't use glutamine is where there is an acute hepatic dysfunction. In all patients who have an acute kidney injury, who are not on dialysis. But if you look at the Canadian guidelines, who say that if the patient is on hemodialysis and on parenteral nutrition, this is a case where you can also give intravenous glutamine as well. These are the Canadian guidelines. But let me come back. So I wouldn't be using in multiple organ failure, especially in very sick individuals, and those whose Apache 2 is more than 10 or 12 and above. Definitely not in API, definitely not in patients whose baseline ammonia is very high. They need not have significant hepatic dysfunction, and also for people with an overt hepatic dysfunction, I wouldn't be using it. Multiple organ failure of more than 2. I mean, these are the standard contraindications where even I wouldn't be using them. Now, where I would use glutamine, I would use almost in every aspect, because glutamine, I'm sure Dr. Gunadhar did mention that the usual cliche saying that glutamine is an essential amino acid. very soon we'll be utilizing glutamine. And also glutamine is one of the gluconeogenic amino acids where the muscles break down, and glutamine and alanine, they form as the nidus for neoglucogenesis. So there is, in most patients, we have a relative deficiency of glutamine. So in all my sick individuals who are not significantly that unwell, but unwell enough to be put in a high dependency unit or even in an ICU, but those with an Apache of less than 2. But if we are using serum intravenous glutamine, I would like to keep a close watch on them. In case I don't, but every patient of mine who's got polytrauma or even especially burns, there are so many papers, especially on burns, there are 1 up to 40 to 50 grams of glutamine, but most of them are enteral. We can certainly give polytrauma because we see a lot of patients, burns, we see a lot of patients. In my surgical practice, we see a lot of GI dysfunction. I see quite a few number of patients who have short gut syndrome. Now, the fuel for the enterocytes of the small intestine is actually glutamine. Secondly are the glucose and other things. So in patients who have short gut syndrome or an intestinal dysfunction or who have maldigestion, malabsorption, resulting at a threat of developing malnutrition, these are the patients in whom I'll be using enteral glutamine. Because within the first few feet of the gastrointestinal tract, once they enter the proximal jejunum, glutamine is rapidly absorbed. And in fact, even the equivalent to increasing the serum glutamine levels immediately. Unlike the standard proteins, if the patient is very sick, then the patients will not have the protein transporters. So yes, I use glutamine in GI dysfunction. Now, patients with chronic non-healing ulcers, right, they have an increased underlying subclinical or even an overt systemic inflammatory response syndrome. And if you look at their highly sensitive CRPs or even their overt CRPs, they're quite high because their inflammatory load is quite huge. And most of the, I mean, as we all know, that I'm sure Dr. Gunadhar has covered, that it is a fuel for, apart from enterocytes, or also for the immune cells. So we need to support our immune system by giving these patients the glutamine. So in all patients who are at an immunologically challenged individuals, chronic inflammation or an acute GI dysfunction, or patients who are on steroids for whatever reason it is, or patients who have some element of autoimmune dysfunction where the T regulatory cells are near exhaustion. So these are the various conditions in which I would give. Now, coming to diabetic foods, there is not much of evidence, but yes, I do use it quite a lot. The other thing I use glutamine is in chronic pancreatitis because these are the ones who have significant malabsorption, malnutrition, resulting at the threat of developing malnutrition, maldigestion, and malabsorption. And I give glutamine in all patients with chronic ailments, including chronic pancreatitis. In patients who are chronically bedridden, in old and infirm, I see a lot of patients in the neurological ICU, not necessarily with Alzheimer's or cognitive dysfunction, but traumatic brain injuries. Very early on, we use glutamine in TBIs, traumatic brain injuries. The recovery phase, there are very good trials again to show that the recovery phase is much faster. So in trauma, polytrauma, traumatic brain injuries, chronic autoimmune disease, and chronic inflammatory conditions in GI dysfunction, chronic wound healing, most of the major traumas, including burns. So there are quite a lot of this. I think I've crossed more than 5 members, Sanjit. So yes, glutamine is, I don't shy away from using glutamine because the main authors of redoxus, subsequently in another journal, ISPEN, they have said that glutamine can be used in patients who actually need it. And in my view, more than half of the patients actually need glutamine to result in a positive clinical outcome. Sanjit.
So I just have one question, sir. Like, do you think that the measuring the glutamine level, or what is your experience? Like, have you ever measured the glutamine level and decide the therapy as per the patients in ICU? Like, any suggestion from your side or comments?
Yeah, I mean, see, even though the guidelines do say that measure glutamine levels even in patients who are very sick, and in case the glutamine levels are very low, then there is a role for giving glutamine. Now, having said that, even in the US, I had the opportunity to actually be in the ICUs of Massachusetts General Hospital last year. And I did ask, I mean, I was with my daughter there who works there. And I did ask them, do you glutamine? Do you do levels? And actually they said, no, they don't have the wherewithal to actually test glutamine, which means that, and especially in India, we do not have it in our hospital. Now, your specific question of do I have any experience? A few years ago, I used to get students from the National Institute of Nutrition, under me, from the institute, and they wanted, the thesis topic. So I did give them the glutamine levels. And in fact, I think if I remember correctly, about 60 or 63%, just under 70% of them did have low glutamine levels. Mind you, the numbers were not huge. There were 16 or 17 patients, but in most of them, the glutamine levels were high. Now, practically, the take-home message is I do not do glutamine levels, but I do not give glutamine in patients who are on multiple organ failure. Right? But I do give blindly. If I am between 0.0 to 0.3, in other words, 20 grams to maximum 30, and the most 40 grams in 24 hours, I'm sure, I can get away with that. But probably if a person has some element of hepatic dysfunction, it's better to actually keep an eye on the cognition at the same time, serum ammonia levels, perhaps maybe once in 5 to 7 days or so, need not necessarily be every day. But I do not do practically, but I have some experience. There is some this thing, but it is not a standard indication as mentioned in the subsidy. I don't think it's a guideline. It's a recommendation by Paul Wishmeyer and others in a subsequent follow-up paper, which was published in ISPEN journals. So I think that answers your question, Dr. Gunadar.
Yeah, thank you. Thank you, sir. Dr. Sanjit, I think you are in mute actually.
Can you hear me?
Yeah.
Hello?
Yeah.
Yeah.
Yes. Yes.
So what I understood from all this is the fact that glutamine is actually an essential amino acid when it comes to illness. And at the same time, it is one of the molecules that should never be used when there is multisystem organ failure. So more than two organs or more than two organs goes down, glutamine is not supposed to be used. But that proportion of patients in our ICUs, in our hospitals are very small. If you look at it, if there's a large hospital, only 1/4 or 1/6 of those patients are the ones that are actually afflicted with severe illnesses. The large majority of patients that are admitted to the hospital are actually admitted with a non-severe illness. That means, or if a 500-bed hospital is taken, maybe there may be 20, maybe 30, 20 patients who are extremely ill with multisystem organ failure. But the large proportion of 400 odd patients would actually be the ones that would benefit with glutamine, is what it appears. Now, Dr. Sriram has actually mentioned over here that there has been a recent data that is actually said I'll just read out the question to you. A recent 2024 publication by Vandala Nutrients 2024 has actually said that there has been no association between all clinical outcomes and critical illness. Now, what it is said is that this particular data that has come from this particular author in Nutrients 2024 says there is absolutely no association between any outcome in critical illness for the supplementation of glutamine. Any kind of comment on this?
I think the
So,
intern can answer that. Yeah.
Maybe I can also put that question into perspective and talk about this. See, this Nutrient 2024 article that came out recently in 2024 was actually a secondary analysis of the effort trial. Now, a secondary analysis of a trial is usually hypothesis generating, and it is really exploratory in nature. It's never confirmatory. So we cannot call a secondary analysis of a large trial to be confirmatory for real evidence. So the particular article that we talk about, nutrients in 2024, of course, cannot be discounted, but at the same time cannot be taken as evidence to say that we should not be using glutamine in critical illness, and it has absolutely no role. Dr. Reddy, do you have anything that you want to talk about this article?
No, but I just not about this article now, because I do not treat critically ill patients, but I'd be skeptical to actually use glutamine like you in patients who are very sick. Those who are not very sick, I don't have qualms. I use them. But having said that, there's a question. I think you are the moderator, so you can read the question. I think somebody asked a question there.
Yeah, so there's another question that comes in. There's another question that comes in that again, Dr. Shriram has actually said that there is no benefit of glutamine in burns. So, Gunadhar, you did have a slide that said you could be using it in burns and trauma, whereas Dr. Shriram has actually put up a statement saying that Helen's article in 2022 actually said that there is no evidence of glutamine in burns. I partially agree to what Dr. Shriram says, because this was the largest article that you could talk about when it comes to burns. It was probably the largest. I mean, yes, it started by thinking that we'll have somewhere around 2,700 patients, and they actually cut down to 1,200. They cut down to 1,200 because of the fact that they just couldn't take up the number of patients. Mind you, this article protocol came out in 2011. It took them more than 10 years for them to actually get this article out. But
Okay.
but then this article was quite eye-opener for all of us, because it did say that in burns, glutamine has no role. But remember this, out of all the critical care articles that you have, or randomized control trials that you have in literature, there has barely been around 5 articles that have actually shown an improvement in mortality. And this was one of their primary outcomes. So I would not take this article by saying that there is nothing to be done. If you actually read that article very clearly, the length of hospital stay does go down. Now, the length of hospital stay going down indicates that there is some benefit. We can't say that there is absolutely no benefit when we look at this particular study. However, I would put caution to the view that, again, when there are 2 organ failures in burns, you are not supposed to use this particular this molecule is what it looks like. I have one question to you, Dr. Gunadhar. If you have a patient with on parenteral nutrition, not sick. I mean, you have so many patients who are on parenteral nutrition, those patients who come in post-surgery who require parenteral nutrition. Would you supplement each of them? Now, looking at all the benefits that you talked about the benefits of the endothelium, the benefits of wound healing, the benefits of preventing an infection, the benefits of so many other antioxidant related features and things like that. So on that perspective, would you give supplemental parenteral glutamine to each and every patient that was on parenteral nutrition, keeping aside those who had multi-organ failure or 2 organs failed?
So basically, what you have pointed out, that to each and every patient. So I don't per se agree to this statement very much, because see, the thing is that as such, the role of parenteral glutamine is not very to a large extent compared to the oral glutamine supplementation. So if you consider to be each and every patient, I say it's should not be like recommended, but rather the patient should be individualized. And I per se didn't come across too much of article or too much of studies actually which shows that even if the patient is not sick, not without any organ failure or not without any supports, particularly supplementation of parenteral glutamine helps to that extent, or preventing the mortality, or overall you can see the great extent to the ICU length of the stay. So only in very few subset of patients, particularly like if I have the facility to measure the glutamine level, particularly that is my one of the good endpoint. And particularly those patients I can definitely think of, and where the patient has undergone some kind of bariatric surgery, where the patient is not able to afford actually take the oral glutamine supplement, those kind of patient I can definitely think of supplementing the parenteral glutamine, but not a standard supplement.
But Gunadhar, the entire point, and if Dr. Reddy is here, is Dr. Reddy here?
Yeah.
Yeah, so there was a very strong recommendation that came out from the Canadian Nutrition Practice Guidelines about IV glutamine. A very strong recommendation that said if you have parenteral nutrition on board, you should be giving IV parenteral nutrition, parenteral glutamine, which actually this year got downgraded to should be considered. Now it says from strongly recommended to should be considered in the last 2 years. So what's really changed? I mean, in the last 2 years, what's really changed that they came down from strongly recommended to should be considered, at least by the Canadian nutrition guidelines. It appears that every patient of PN, we should consider to give glutamine. Do you do that in your regular practice, Dr. Reddy, sir?
See, the patient, if the patient is on dialysis and patient is on a ventilator and patient is on parenteral nutrition, then there's no question, there are no two doubts about it. You can also give glutamine in addition, provided your total protein intake is well within the accepted range of that particular patient. But I actually am very, very skeptical with strong statements such as, quote unquote, glutamine has no role in any burn patients. Now, that is nonsense. You can't say that. Glutamine has no role in any of the ICU patients. No, that is not. You have to individualize the patients. The reason I say that is every person who uses any molecule, he or she should be aware of the physiology of that particular molecule and then make his or own decision. Guidelines are meant only to guide. They are not mandatory. They are not mandatory. I have repeated this statement so many times. Now, if you are giving glutamine only to a burns patient, thinking that let's say a burns patient has 20% burns of total body surface, right? He's not on significant multiple failure. Yes, go ahead and give glutamine because that helps. We know that it reduces the heat shock protein 70. We know that it downgrades the inflammation. It has its own antioxidant effect. I mean, what more you want? You can safely go ahead and give glutamine. This particular analysis is pretty old. Perhaps it's come out now. So I am very, very skeptical, and neither do I recommend it in such strong words that there is no role of glutamine in burns. So I don't agree with that. Regarding a pertinent question of the Canadian guidelines downgrading it to can be used, it depends. Most of the guidelines, because I am now involved in the European guidelines for surgery, which is coming up in September 2024. Some of the previous guidelines, we have also downgraded them that they can be recommended. What actually happens in these guidelines is they look at the previous evidence and vis-a-vis, they look at the evidence since the publication of the previous guidelines and see has there been any other prospective randomized trial that actually reiterates what they have already said, or there are some observation studies, or there are no studies, or there are some studies that show the negative correlation. If there is a negative correlation, one or two, so they downgrade this recommendation to can be recommended in their expert view. So they have recommended it rather than it being a guideline. To get evidence 1A, you need plenty of randomized controlled trials from at least 2 different centers with at least 100 to 120 in each of these trials. So if they do not have that kind of evidence, then they'll actually automatically put it to recommended. So maybe down the line, maybe in 2026, the Canadian guidelines say totally that glutamine cannot be used, should not be used, or maybe they'll revert back to their original statement saying that they strongly recommend it. We'll have to wait and watch. Meanwhile, one should be aware of the physiology and individualize to the particular patient, which Dr. Gunadhar actually said a few minutes ago, that it has to be individualized rather than one rule doesn't fit all the patients. Sanjit.
Yeah. So, so well said, sir. So, Dr. Gunadhar, there is a question that is
I just have a, I
There
just
is a
have
question. Can
one
you hear me?
comment. I just one comment here.
Yes, please, Dr. Gunadhar.
What about this Canadian nutritional guideline? Basically, said they don't have a uniform policy for the nutritional guidelines. If I remember, for this Canadian, just like ISPEN or ISPN. So particularly, they have like guidelines for the something called as the like the supplement, the nutritional supplement. So actually, whether that is a strong recommendation or that is to be practiced and followed uniformly across the world, that is also, I think, needs to be little debated, because the whatever they call, that is called Canada's food guide actually. So they have defined guidelines, but not that strong guidelines, just like ASPEN or ESPN. So
No, Dr. Gunadhar. So there is a CPG, a Canadian practice guideline that comes out once in 2 years, once in 4 years or so. So I'm talking about the CPG, the Canadian practice guidelines, which actually goes ahead and talks about these things, very similar to the ASPEN and ISPEN, and it is definitely chaired by very, very prominent personalities like Darren Hill and things like that. So there is a very good question that's come in over here, which says, See, and I think that's related to the fact that you have GI dysfunction in children, and there many children do have GI dysfunction. So the question that comes in over here is, what should be the age recommendation, or is there an age recommendation for enteral glutamine? I mean, do you really give it to babies, neonates? Can you do that? That's the question that's coming over here. And can you answer that question, Gunadhar? Do you think that we can give it to babies, or is there an age limit that you would think of, or you would just say that because you're intensive care, adult intensive care, I don't know about babies. What's the entire thinking?
No, see, most of the literature and most of the studies, what I have found, they have mainly, like, particularly as I am an adult intensivist, of course. So most of the data and studies, what I have found, is particularly applicable for the adults. Actually, I don't have much idea regarding the neonate and pediatric population, but whatever the few, like, literature what I have came across particularly, so it should be like more than 16 years, 16 to 18 years.
So what the entire thing is about, the question is this way, that there is a theoretical concern, that supplementing glutamine, via its metabolic byproducts like glutamate and ammonia might be excessive for the neonate. That's the entire thinking. The glutamate and ammonia that comes in might have adverse neurological effects on with high concentrations in the young infants. But all said and done, there have been multiple trials that have looked at young infants with glutamine. To get ethics clearance in a US based study for young infants means that it could probably be used. So young infants have used it. However, it is important that it is you actually if you are a dietitian, it's important, or if you're a doctor, it's important that you understand with the pediatric specialist whether we can actually do that, because there would be other factors which would be present in that particular region. But yes, glutamine supplementation can be given at least till the age of above the age of 5 years. Less than 5 years, it's important to have a discussion, and the dose seems to be 10 grams in those cases, up to 10 grams. Well, there's another question that has come in from Shabishta. She says AKI, multiple organ failure, sepsis, we can't use glutamine. So can we use it in CKD patients with maintenance hemodialysis or continuous ambulatory
I think
peritoneal
this is
dialysis?
discussed actually. Sir has already, like, highlighted this point. So patients who are on maintenance hemodialysis, particularly, you can, if the glutamine levels you suspect to be low, I think you can give.
But the
This kind of
question that
patient.
comes in over here is, can you give it as a routine? The question is that, can we
No.
use it as a routine to patients who have maintenance hemodialysis? That's the question. As a routine. See, what probably the question is all about is, a CKD and a maintenance hemodialysis patient will have a frailty. There is going to be some sort of frailty. The question that's coming over here is, should we give this glutamine as a conditionally essential amino acids that will prevent maybe muscle breakdown, maybe sarcopenia, maybe an antioxidant effect, preventing infection because you got lines in place and things like that. So that's the question, should we give glutamine that way?
Basically, routine, still it is debatable, because even if they are CKD, they are having some or more other organ dysfunction. CKD patients are known to have, like, a dysfunction of the other system because of the organ crosstalk actually. So if you, like, really, like, want to give in a patient who is, like, requiring glutamine because of the sickness per se, or because of the nutritional deficiency, or you feel that the muscles are wasting, and those kind of scenarios, you can go ahead. But for the routine use, just for a normal CKD patient, just for maintenance of the nutrition, still I feel it is a debatable area.
Okay,
Routine
so
should not
Dr.
be
Reddy, are
practiced.
you there? Dr. Reddy, are you there?
I think last September, I gave a lecture on nutrition in CKD patients in relation to muscle loss. This lecture was in North Dakota in the United States. And there, before that, I did quite a bit of a reference. And yes, see, CKD patients, as Sanjit has said, most of them are sarcopenic, and majority of them have frailty. Now, where is glutamine? Glutamine is within the muscles, and there is sarcopenia. So these are the patients, and these are the ones who actually need, small amounts, but with good physiological aspects. You can't expect to give the whole, the polymeric feeds in these patients at 1 gram or even 1.1 gram or 1.2 grams if they are on maintenance hemodialysis, as opposed to 0.8 grams in non-dialytic patients. There is no way we can achieve that, at least in most of the patients. So there were a couple of papers that actually said that those who were put on supplemental glutamine of 10 to 20 grams daily, who are on maintenance dialysis, they are the ones who had less incidence of sarcopenia, increased muscle function, And I don't think they looked at the frailty, but at least they looked at these sarcopenic indices, which is the mass as such and also the muscle function. I see quite a few patients with CKD because they are sent to me for nutritional interventions. And in all of them, actually, I say take at least 20 grams of glutamine daily because, mind you, most of the Indians, their protein intake is suboptimal. And I want an amino acid that is absorbed very rapidly. As Dr. Gunadhar said, they have some element of organ dysfunction. They're not in failure. There's a big difference. Organ dysfunction versus organ failure, and they have some element of malabsorption, maldigestion. Again, I'm coming back to these two terms very frequently because that is the denominator in all these patients, especially CKD patients. So these are the ones who would benefit from glutamine. I also tell some patients to actually even have whey protein for that matter, but that's another topic for another day as such.
But do you find their duration of the dialysis has been reduced in any means, or their, like suppose a patient is twice in a week on dialysis, is there any on the supplements sometimes the dialysis time is get reduced or something like that?
I don't think glutamine per se has a direct effect on the renal function. I'm not aware of any of that physiology. I'm talking, this is purely in terms of the threat where every patient who's on maintenance dialysis is at a threat of developing sarcopenia. Remember, dialysis machine is not as intelligent as a nephron, as a glomerulus. These patients lose, each time they undergo a hemodialysis, they'll be using significant amount of proteins in the dialysis fluid that goes out. Even in PDs, peritoneal dialysis, they lose quite a lot of protein and that is not reabsorbed back. So, yes, so we need to give glutamine in them to avoid further damage and not necessarily to actually improve the kidney function. Now, if the patient is on hemodialysis maintenance, that means he's on end-stage renal disease. And I don't think these are the ones who, let's say, grade 4, they'll come back to grade 3 or so just because you're giving glutamine. I don't think so. I'll be very, very surprised if such cases are reported. So the objective of giving glutamine is not the kidney function as such, but for the muscle function and for the quality of life in these individuals. Sanjay.
So there are actually, sir, very few case reports where that it has been found that this glutamine is particularly toxic to the cells, because sometimes if the level fluctuates too much or if the level goes very high, sometimes they may get accumulated and they cause cellular swelling, and sometimes they can cause cell death, including the cell death inside the brain and cell death inside the liver or to other vital organs. This is very.
I completely agree. But mind you, most patients, at least my patients who are on constant hemodialysis, they are under constant biochemical surveillance, aren't they?
Okay.
Pre and post, they are on biochemical surveillance, and very frequently, at least once or 1.5, 6 weeks or so, they'll be having their liver functions checked, in addition to their general physical examination. So these are there's more than one way you can actually say if the patient is going into toxicity just because we are giving glutamine, right? If they fall out of our net of monitoring, then yes, there may be a chance. But these are the ones, that's why I say you need to know the physiology. Every person should know the physiology when we are intervening, especially in such nutrients, especially dynamic ones such as glutamine. Sanjay, before you go to the other ones, actually, I hope you get some point because there's a question of glutamine in PCOD and obese, and somebody has said, can we use glutamine in?
You can take that question, sir. You can take that question. Yeah. So to put this all flat, see what happens is that if the patient is having a stable renal disease and he's on glutamine, definitely the apoptosis and the antioxidant effect of glutamine would probably help this patient from progressing from a worse grade of kidney disease. But all said and done, when you have a patient on maintenance hemodialysis, glutamine is not something that you should be pushing in a very big amount. Though it can be given in a smaller amount, at a larger amount, it is going to cause problems because we know that glutamine and the kidneys don't go along well per se. So the larger amounts are not something you would like to do. A smaller amount is something you'd want to do in these cases for the sarcopenia that these patients might have. So the next question that comes is that is there any positive role of glutamine for pressure ulcer or bed sore? 100%. I mean, just Gunadhar
Yes.
went exhaustively at this particular question, saying that if by any chance there is bed sore, it definitely prevents the incidence of pressure ulcer or bed sore. It in fact improves the healing of these bed sores too. The next
Absolutely.
question that comes up over here is dose of glutamine for obese patients. What would be the dose of glutamine for an obese patient? It's a very tricky question actually, because we don't know the actual dose even for the adult, normal adult. As of now, we are still finding doses for the normal adult also. So in that case, there are multiple studies that have looked at 0.5 grams per kilogram per day. In fact, the latest Burns trial that we talked about just now also started glutamine at 0.5 grams per kilogram per day. So it's 0.5 gram to 0.75 gram kilogram per day. So it's anybody's guess. We, as of now, we are still finding doses. So do you have any recommendation? Gunadhar, do you have any recommendation
No,
for
no,
the
no,
dose in obese individuals? Dr.
no.
Reddy, do you have any data on obese individuals and the dose recommendation for glutamine?
No, but I would just say that whether you're giving protein or whey protein or glutamine or anything, be mindful that one does not cross the threshold of their protein requirements.
Yeah.
Remember, whether it is protein or fat or carbohydrates, it enters the Krebs cycle, and you're increasing the de novo fatty acid synthesis, FAS. So excess protein actually in obese patients will actually cost you more. It'll not help. But if somebody his or her intake is suboptimal, yes, you can give. Why it's not going over? Do not do what the Redoxys has done. Give the daily proteins and glutamine in addition. No, if you're using glutamine, be mindful. Consider that in the total calculation of total protein intake, because glutamine after all is an amino acid. The same for PCOS, and I'm sure the same for specifically for pregnancy, even though I do not have any experience in pregnancy, but I don't think it's the contraindication.
So what sir says is so important. I mean, when you use glutamine, use it as a fraction of your total protein. Actually, don't add glutamine on top of your protein. This is a very simple thing to do. Actually, this will actually remove the problems that come because of the high amount of glutamine that we add. So you use glutamine as a part of the entire protein that you're getting 1.5 gram per kilogram. Put the 0.5 as glutamine is what it appears. So that's a very good suggestion that we've just now got from here. Now I'm going to ask. I need to ask a question, and let's see, Gunadhar and Dr. Reddy, whether you can give me some data on this. See, I was consulting a celebrity who basically looks at a lot of YouTube videos. Okay, and this celebrity came and told me, I've got cancer. And I had prescribed glutamine. So just like how Gunadhar explained, that glutamine is one of the parts that feeds the tumor. The tumor cells are known to proliferate, as we all know, when you give them glutamine. So am I actually poisoning this patient with glutamine in such cases? Because a cancer, you just now said it's great for immunity, it's great for, even in cancer. But then the question that comes is, by giving glutamine, am I causing harm in any way? Or should I just refrain from using glutamine when the patient is a patient of cancer? Gunadhar, you can go first. Then
Actually, this is a very controversial area, but still there are a lot of research and a lot of studies are ongoing. Actually, when I asked my oncology colleague, actually, so sometimes what happens, they are also sometimes scared that am I going to do any harm to my patients? But whatever the evidence-based literature is there till now, that suggests that glutamine causes more benefit than actually the harm. So there are like you have to ideally see what type of cancer and what are the different, like what the patient is, whether actually patient has received radiation, chemo, or whether the patient is subjected to chemo, radiation, and before that what is the nutritional status actually. That is one thing. And second thing, in those cases, whether that effect of the cancer, how severe it is, like particularly whether it is going to affect all your organ system, particularly patients who are like in a tumor lysis syndrome, or particularly patients who are having severe systemic inflammatory response syndrome. In those cases, actually, because sometimes more or less they are having organ dysfunction, in those cases the glutamine supplementation is prohibited. But to promote the normal recovery, to promote the normal muscle function, to promote to prevent the sarcopenia, and sometimes to promote the normal cell function, and to actually promote the your all these leukocytes and neutrophil function actually, which actually kills the cancer cells. They just now have shown actually those cases the glutamine role is very useful actually in such patients.
Dr. Reddy, what is your take on giving glutamine to cancer patients?
Yeah, I mean, I think I covered this in my chapter, which I wrote in the ISCCM chapter called Immunometabolism. It all bogs down to the tumor microenvironment. Because even though oncologists, with due respect to them, most of the oncologists I have seen have no idea about the nutrient physiology and biochemistry, right? With due apologies, that is. It is not to put them down, but they don't have time to actually go through what the recent data. Now, all cancers, you cannot say that in each and every cancer, glutamine should not be given. Some solid organ tumors, like there have been reports of breast and also even bronchial carcinoma, various kinds of lung cancer, small cell cancer, all of them are glutamine avid cancers. In other words, the more glutamine you give to something like giving excessive glucose to them, they actually harbor on these. But if you look at the tumor microenvironment, there is a competition between the natural killer cells, which are the real cells actually fighting the tumor cells. At the same time, the tumor cells themselves. And it is the tumor cells which actually avidly consume in cases such as the lung cancer and other solid cancers, they consume. Now, in my a few minutes ago, I said that glutamine is the fuel for the immune cells, and which Sanjit rightly said that what about the fuel for the immune cells? Yes, we do need to give glutamine in these individuals, but not every. There is good evidence that in patients with hematological cancers, they do well with glutamine supplementation. Again, I'm not very sure at this point in time about the dose. Certainly in those with radiation enteritis, and of course, each and every patient who has mucositis due to chemotherapy, because again, glutamine has been shown by its virtue of it being a fuel for the enterocytes, it actually helps. It is absorbed and utilized by the enterocytes, and it is not necessarily taken up by the tumor cells. So I think we need to individualize these patients. If they have solid tumors, you need to go a bit slow. But mind you, a significant amount of amino acids which you give, if the person, a cancer patient, has adequate glutamine synthetase, he or she is synthesizing glutamine, at the physiological rate at which it is manufactured in those individuals who are having complications due to therapy, cancer therapy, and those individuals, especially with hematological malignancies, there may be a role to consider glutamine. So to say that in all cancer patients, glutamine is a big no-no, I think that needs to be taken with a pinch of salt. Definitely, glutamine can be considered in some.
Yeah, it's like talking when Simon Seyfried, the person who's been actually talking about this on YouTube since the last 4 or 5 years. I mean, when he talks about it, he talks like even glucose is problematic. That doesn't mean we stop giving glucose. I mean, glucose is consumed by tumor cells, and tumor cells are averse to glucose, so we should give them a ketogenic diet. All this is, the problem that comes in with little knowledge and less randomized control trials. So I don't think it's a commonplace to actually stop glutamine, especially because, as Dr. Gunadhar rightly put in his talk, that mucositis, one of the biggest problems that come in with chemotherapy, can actually be taken care of by the addition of simple thing like glutamine. There's another very important question actually coming in, and this is a very practical question written by Bhavani Sundari. What she's asked is, what is the glutamine available in the market? Most seems to be sports nutrition or fitness supplements. So which should we actually order for when we're actually giving glutamine? Gunadhar, what do you order usually when you're giving glutamine? What is it that you're ordering?
No, actually, we order the standard prescription, that L-glutamine.
L-glutamine, but is it medical glutamine, sports nutrition glutamine?
No,
Is this glutamine from a company? What is it?
We actually don't know actually what all these companies, they have claimed to be having a good amount of glutamine in their product, and how the manufacturing process and all. But as a standard formula, like from the standard nutritional company, like particularly if you see Hexagon.
Yes. Okay.
Yes.
So
So
you're basically using a company like standard company like Hexagon from where
yes,
you're taking
yes,
glutamine. Sir,
yes.
do you have any specific this about any glutamine?
Same thing. I use products from medical grade companies because I'm sure they have SOPs in place to look at the quantity or sorry, the quality of whatever. I think I do not know about Hexagon, but I know for sure that Fresenius Kabi manufactures their product in somewhere in North India, somewhere in Haryana or Gurgaon, in that particular area. When I asked them, do you have SOPs? They said yes. In the
Yeah,
past,
yeah. So, so
even planning to do
most of
that.
these companies do have
But
very good SOPs, including Hexagon for certain. There is no doubt about it. Hexagon is not one of those companies. Is they also have their this SOPs. Sir, there is one very important question that I would ask both of y'all. Okay, which has come over here by an anonymous attendee. It says, if you are giving a patient glutamine, say I have started this patient on glutamine and the patient is in the hospital, then what parameters we should check regularly to see that it is not having an adverse effect? I mean, it's a very difficult question to answer, but what is the parameters we should check regularly to see that it is not having an adverse effect? Let's take the example of a patient who's been admitted for, say, a medical illness and he's not very ill. And this patient, you have started this patient in the wards, and patient is going to be there in the wards for the next 20 days because he's an PO of unknown origin, and you're trying to treat this patient for the last 20 days. And 20 days, you're going to give him glutamine 15 grams twice in the day, 30 grams totally you're giving. Okay. So what are the parameters that you'd like to look at to check regularly to see that it is not having an adverse effect? Sir, I'll start with you first.
yeah, I mean, it's quite simple actually. It's not as difficult as you make it out to be. Any intervention, be it antibiotic, be it nutrition, be it blood, be it glutamine or anything, you actually look at the patient's improvement, patient's response, isn't it? You just don't start the patient on, let's say, 1st of August and go back on 20th August to see how is the patient doing. You assess the patient daily to see, look at the clinical course. Is he or she improving? Is he status quo? If the patient is not improving or the patient is status quo, you say, hey, am I missing something? Or is it an iatrogenic, the medicines which I'm giving, be it antibiotics or even glutamine for that matter, is it causing anything? Now, what does glutamine do? It can harm the kidneys, it can harm the liver. So look at the liver functions, look at the kidney functions. I mean, it's not rocket science as far as I'm concerned.
So,
In
so it appears, so what by what sir's talk it appears is that you monitor the liver functions and the serum creatinine on patients who are on glutamine. Am I getting this right?
No, it's number 2 and 3. Number 1 is clinical assessment.
Clinical
Number
assessment. So
yeah,
the question here is what parameters? So the parameters, the clinical parameters first.
yes.
Second would be liver function test, and the third would be creatinine. And
I would
of course, when you have a patient of PO, there are loads of other causes that will cause the liver functions to go up, including antibiotics. There's loads of other things that will cause the creatinine to go. That's dehydration.
I would
I still don't know the parameter, if you ask me for
yeah.
certain, that will be linked closely to glutamine.
One thing is, yeah, this is my personal experience. We presented this way back in 2004, I think, in Glasgow, in the ISPEN conference. In those days, we used to have intravenous glutamine in India called glamine, right? And that was my paper on. Now, if we use glutamine, the serum creatinine goes up. The blood urea goes up. If the urea is going up with the normal creatinine, that means this patient take it for granted that it is because of the glutamine. Now, this is the time where you look at the total protein intake of the patient. Am I overfeed or am I giving the patient more protein? So you need to, assess. So clinical improvement, renal functions, number 2. Number 3, daily we can't do liver functions. So probably we can do once in a week or once in 10 days, just to keep an eye. But again, if the creatinine is going up, look at the urea as well, and look at the other parameters as such. Look at the urine output, look at the electrolytes, which are so sensitive, especially the gold salt of our body's sodium. Is something happening to the sodium? Has the kidney lost its reabsorption of the sodium? If the sodium is falling down, then you stop glutamine immediately and reassess the whole thing, and then go about it. So clinical assessment, renal functions, number 2, not just creatinine, but all the functions frequently, and then liver functions once in a few days. Sanjit.
Yeah, Gunadhar, about anything that you have to add to this?
No, just for a few lines, sir has absolutely clarified that this doubt actually. So the thing is that your patient is your best judge actually. So always ask any symptoms, whether it is a minor, moderate, or severe. Many of the patients sometimes they may be complain of some kind of nausea, some kind of discomfort, but actually they may not be related to glutamine, but sometimes because of their comorbidity also. But sometimes glutamine may be a contributing factor, like earlier signs of renal dysfunction. If you don't have a facility to monitor, actually sometimes the patient may complain of nausea or some kind of uremic symptoms, but sometimes these earlier symptoms should not be missed also. Always look at the good urine output, always look at the patient bedside and stand and see that the patient should be vitally stable and patient should not have any kind of allergic reactions or allergic things at the bedside. Then comes your biochemical parameters, like either you can, as sir rightly told, like monitoring the electrolytes and urea, which is a very simple test actually. And also look for the liver function test at least 3 days or 4 days in a week. One means once in 3 days or 4 days. And if possible, like always monitor the progress of such, follow the trend. Sometimes the trend gives us a best result rather than an absolute value. That is what my suggestion actually over a
Yeah,
period of time.
so I think this question that comes is something that it comes very often in sports nutrition. People in the gyms and use health nutrition supplements that have got scoopages of glutamine. And probably I was party to one of the cases that happened recently where, not recently, around 2 years ago, where we had a sports nutrition person, a gym person who took so much of glutamine that he developed hepatotoxicity. He came into the hospital with hepatotoxicity. So the what I learned from that is that patient 3 or 4 days ago had started developing an abdominal pain, bloating, and a feeling of not feeling okay. So bloating, abdominal pain was what he had. Look at those symptoms, as both of you rightly said. Those symptoms are something that comes in very quickly. And then he disregarded those symptoms, came back to us, and that's when we found his aspartate amine to be very, very high, and hemoglobin, thrombocytopenia, and he was already in DIC when he came in. So clinical feature again goes back, is very important, paramount in such cases. And it's been and thank you, Dr. Reddy and Dr. Gunadhar. It has been a fantastic discussion today. I learned quite a bit from both of you all. And I will hand over the session to Dr. Jairam for conclusion. Before which, if Hexagon, I'm very happy for Hexagon to have sponsored this entire webinar. Dr. Jairam, over to you.
Thank you.
Well, first let me thanks to Dr. Sanjeev and the ISPN team, Mumbai team actually, and the whole ISPN team, national ISPN team also, Reddy sir and all the organizers actually. This is a very, I think one of the best to best programs, and this enlighten our knowledge and not even us, to all the person who are working in critical care medicine and in a hospital setup actually. So these things should be should not be lightly taken, and every message should be clear and loud, and it should be practiced from the bench to bedside. So Dr. Sanjit has actually tremendously done a beautiful job actually, I can say, and thanks again from my side.
Thank you, Dr. Gunadhar.
So before giving vote of thanks, Hexagon Nutrition want to play a small video. So over to Jyoti.
Yeah. So first of all, thank you so much for the team of the ISPEN. It was really very insightful session. So Dr. Gunadhar Padi and even Dr. Sanjay Sashidaran and Dr. Reddy sir, they had a very brief, very good insights we have got where the glutamine usage. Yes, there are the many of the controversial and the usage are also been there. So sir, if you allow, can I just take the brand name? So
Yes,
Hexagon,
yes.
yeah, thank you so much, sir. So Hexagon Nutrition, we have the brand name which is known as a Metagluta ZS. So you can find our team are also been meeting, or you can find online also the pura product monograph and the brief. We can just mail you out. So thank you so much. So just before ending the session, I just would like to take you through the corporate video. So please allow me to share the video. So where the screen is visible.
Yes.
Thank you, sir.
Nutrition, a catalyst for robust health and longevity of life. The overall market for micronutrient premixes is set for a high growth trajectory in India. We at Hexagon Nutrition Limited are the only holistic nutrition player to offer products across 3 verticals: clinical nutrition, micronutrient premixes, and therapeutic food.
Nutrition is among the top 3 manufacturers in India with an exporting base across 70 plus countries and trading units established in South Africa, Uzbekistan, and Hong Kong. Our consumer brands are offered through 17 different products. Since we have the entire nutrition portfolio under one roof, we are able to develop customized premixes and products with agility, cutting-edge R&D, and analytical abilities.
As a fully integrated company, we are engaged right from product development to formulations, including research and development, manufacturing and marketing, with a focus on quality. We believe that R&D is critical in maintaining our competitive edge. Our R&D team strives to identify and develop new applications, combinations, and dosages of active nutrients with beneficial health effects in order to increase our product portfolio.
Despite the diversified diet in households, the Indian population suffers from micronutrient deficiencies, leading to malnutrition and hidden hunger. Foods focused on immunity enhancement are capable of addressing malnutrition and hidden hunger concerns on a global scale and lead to a promising future of the food and nutrition industry.
We operate from 3 manufacturing facilities: Nasik, Chennai, and Thoothukudi. Our manufacturing facilities are strategically located in close proximity to the ports. Our products have been exported to over 70 countries worldwide. We have established 3 international offices in South Africa, Uzbekistan, and Hong Kong. Having started our business in 1993 as a micronutrient formulations player, we have moved up the value chain to develop our brands Pentasure, Opesigo, and Pediagold, now leading names in the health, wellness, and clinical nutrition space. We are a pioneer in micronutrient premix formulations business in the South Asia and market leader in customized and staple premix formulations in India. We have pan-India omni-channel distribution capabilities, supported by our presence across retail pharmacies, hospital networks, prominent e-commerce players, online pharmacies, and our own websites to address different consumer demands. Over the last 28 years, we have established long-standing relationships with marquee domestic consumer companies and global customers. We stringently adhere to compliances of environmental protection, corporate governance, and corporate social responsibility. Over the years, we have garnered a number of industry awards. We are led by professionals turned entrepreneur promoters with experienced management team and backed by a reputed institutional investor.
Hexagon Nutrition is walking towards endless possibilities to grow and serve the unmet nutrition demands. We are emphasizing the enhancement of the clinical nutrition product segment, which will focus on newer therapy areas like maternity, gynecology, fertility, healthy aging, etc. The company has launched fertility nutrition products under the brand names of Fertox and Fertomen and Fertova and Fertonisa in select international markets on a pilot scale basis. We are capitalizing on the awareness and the requirements to address the growing nutrition market with a focus on global expansion and the launch of newer clinical nutrition products.
Hexagon Nutrition Limited. Nutritionally yours.
So thank you so much for your patience listening. And over to Dr. Jairam, sir. Thank you, sir.
Thank you, Gunadhar sir, for such an excellent presentation and very informative session. Thank you, Sanjit sir, for moderating this session. I would like to thank you, ISPEN and Dr. Sanjit sir, for allowing ISPEN Mumbai branch for conducting this webinar. I would also like to thank you, Hexagon Nutrition, for sponsoring this educational session. We'll also expect for further participation in educational activities of ISPEN Mumbai branch. Many more webinars of the ISPEN Mumbai branch will be in the line. Next webinar will be held on 3rd September, which is on trace elements in nutrition. Link for next webinar will be shared shortly. The other workshop on the nutrition in diabetic foot will be held on the 29th of the September through the DFSA con. And with this, we are ending this session. Thank you all for joining this webinar and participating in much more number and attending this session till the end. So thank you.
Thank you very much. Bye-bye.